Great. So without further ado, I would like to invite Professor QRISK to begin the webinar.
Great, thank you, Vicky, and welcome everybody, and thank you very much for coming today. Can everybody see everything okay? Is the slideshow not started yet? Is that better? Right, the silence I'll take as affirmation that is fine. Okay, so as Vicky said, we are based here at Staffordshire University, and before we get into the presentation itself, I just wanted to say a little bit about who we are and what we do. So we're based in the Centre for Health and Development, or CHAD for short, which has been operational since about 2016. We've got a fairly broad remit of research around health improvement and health inequalities, organised into 4 broad thematic research areas, and the healthy living theme is where the RICO study fits. So RICO study started in 2017, I think. It finished last year, and the report will be out hopefully within the next month or so. I was the project lead, but it was very much a team effort, and there is a team there. So we've got Vicky, you already met, Dr. Lisa Cowap, Professor Diane Crone from Cardiff Met, Dr. Lizzie Cottrell, so I'm going down the left-hand side as you can see it, Professor David Clark-Carter as an emeritus professor here, Dr. Naomi Ellis on the other side at the top. Oh, I'm echoing. Okay, that's better. Professor Ruth Chambers from the CCG here, Professor Sarah Grogan from Manchester Met, and Anna Morse from Staffordshire University, who helped to project manage. So it's a team effort. We were funded by the NIHR through the Health Technology Assessment Programme. I assume everybody will know this by virtue of being here, but NHS Health Checks, by way of a bit of background, is a national programme with a focus on cardiovascular disease prevention and targeting those aged 40 to 74 years old in England. Typically, they are primary care based, and it'll be a consultation delivered by a practice nurse or a healthcare assistant. And a usual health check consultation should comprise 3 main parts. So first is measurement of CVD risk. Second is communication of that risk to the patient, and then third should be informed by the second bit, that there should then be an informed patient-centred discussion about how to manage that risk and what to do next. Public Health England, who manage the national programme, have developed best practice guidance and a competence framework for staff practitioners who deliver the programme. And in that, it does state that practitioners should be able to communicate CVD risk so that the patients understand, and that should lead to this person-centred conversation about risk management and using things like brief interventions and motivational interviewing. When we set out on this study, there was a real lack of knowledge about what discussions actually take place when discussing CVD risk in the health checks. There were some indications of some issues around understanding and perceptions among patients and practitioners about what the risk is and what it means, but we didn't actually know what conversations were taking place and how it was actually explained to patients in practice. And so that's something we were really keen to explore. Our overall aim then was to look at practitioner and patient perceptions and understanding of CVD risk, the associated advice and treatment offered in the health check, and how patients respond and their intentions and actions thereafter. And we did that, looking at health checks that were delivered using 2 different types of CVD risk calculator, so QRISK 2 and JBS 3, and I'll talk about those just briefly now. So QRISK 2, I'm sure many of you or all of you are probably aware, is presented as a percentage risk of heart attack or stroke in the next 10 years. So it's a short-term risk estimate, and therefore age is a very strong influence on what that risk is. Obviously, the older you are, the higher your risk is going to be, and that can actually lead to some underestimation of risk or CVD risk in younger adults who may have other risk factors that aren't factored into the QRISK calculation, such as physical inactivity, excessive alcohol consumption, poor diet, and so on. So there's some limitations with the short-term percentage risk score itself. Another limitation is the reliance on patient numeracy, because it's a percentage. And if an individual struggles to understand what that means, then obviously that's going to be a problem. In 2014, JBS3 was launched in some sense to try and address some of those problems, some of those limitations. So first, it's focused on lifetime risk rather than short-term risk estimates. So age is less of an issue in that, less of a driver in how these scores are calculated. The second is that there are a range of metrics to accommodate the range of patient preferences for how they want to receive and understand CVD risk. So, for example, you can see on the screen there, we've got heart age. So there's an image of a heart with the heart age next to it, and it should be quite intuitive for somebody. If their heart is older than them, that's an indication of elevated risk. Something needs to be done. On the top right, you can see there's event-free survival age. So that is the age that somebody could be expected to survive free from a heart attack or stroke. And it's shown as with a visual analog scale, as you can see. A percentage 10-year risk is also in there. And then at the bottom, there's this lifetime trajectory of percentage survival free from a cardiac event. And you can see that percentage chance of survival free of a cardiac event reduces as people get older. And then there's the risk modification function, which means you can show the practitioner can demonstrate to patients the potential benefit of making changes such as smoking cessation, lifestyle changes to reduce blood pressure or cholesterol, and the effect that would have on their overall risk score. So there's some interactive function there as well. And then finally, as you can also obviously see, there are visual displays. It's not just the practitioner telling the patient to score. They can look at the screen and they can hopefully get more engaged with that information. So that was the idea, but when we set out on this study, we didn't really know what the actual benefits could be. This slide just is a very basic schematic of our overall study. Because we were interested in understanding what took place in the health check, what was said, by whom, and also the potential benefits of JBS3 over usual practice, we wanted to use video recording. So we recorded over 170 health checks across 12 general practices in the West Midlands. Those general practices were split into two groups, so we got pairs of practices matched approximately by deprivation of the surrounding area, and we randomly allocated each of those practices in each pair to either the QRISK2 or the JBS3 group. So the QRISK2 was like our usual practice group. They were basically told to carry on using QRISK2 as you normally would in a health check, because that is usual practice, and we will video record it. For the JBS3 group, practitioners were asked to use JBS3 to deliver a health check as normal, but use JBS3 to communicate CVD risk. And we did give some introductory training, some materials, and offered ongoing support as well, should the practitioners want it. So those 173 recorded health checks gave us a really rich data source. So firstly, we did some quantitative characterization of that, and I'll talk about that in a second. We did that for all of our recorded health checks. We then transcribed 128 of those, so 64 per group, and they were subject to some in-depth qualitative analysis. That was a really big data set for a qualitative study. We also did video stimulated recall interviews, or VSR interviews, with a subsample of 40 patients, so approximately 20 per group, and for all of our 15 practitioners who were involved in the study, they also all did an interview. So a VSR interview, video stimulated recall interview, is much like a normal semi-structured interview, where the interviewer, the researcher, has a series of questions, and it's more of a dialogue, sort of a guided interview. around certain topics, in our case very much focusing on the CVD risk bit, but for VSR interviews we also used excerpts from the video recorded health checks to kind of prompt recall and reflection. So patients were shown video clips of their own health check to enable them to recall how they felt at the time, how they received the information, how they felt subsequently, intentions and actions thereafter. The practitioners were shown clips from a number of the health checks that they'd done to enable them to reflect on their practice and what they did and what they understood and how they felt about trying to communicate CVD risk. I mentioned that quantitative description of what took place in the health checks, and to enable that we developed this second-by-second coding framework specifically for this study. The framework comprised 36 items, which were grouped into those 6 categories, as you can see there. The CVD risk discussion, that was the category of primary interest to us. And knowing who was saying what at every second of every recorded health check gave us some quite useful insights to enable some between group comparisons on things like how long the health check was, how long they spent discussing CVD risk, who was most dominant in the conversations, and a range of other outcomes. So I think that's all I'll say on the methods. There'll be a lot more in the report when it comes out. The sample, so who was involved in the study? As I've said, 173 patients from those health checks. We did do individual patient stratification based on age, gender and ethnicity to make sure we got as far as we could a good mix and a good spread within the sample, and that was broadly successful. We got a very good equal split by gender. The age range and distribution was approximately right for health check. Our ethnicity breakdown was about right for the region. We were slightly under on, we didn't have quite as many patients in the moderate to high CVD risk categories as we would have liked, but we did fairly well overall, I think. Practitioners, we had pleasingly all of 15 practitioners from across our 12 practices all took part in the VSR interviews. They ranged in experience of delivering health checks from less than a year to about 9 years. So some of them have been delivering them from the start of health check when the study took place. And when we asked about training they'd had in the health check, 6 had had none, and 9 had some training, but it was sort of generic, focus on process, how to deliver the health check rather than the risk communication and things we were looking at. So the challenge for today was to try to distill what is a lot of data and a lot of findings into a short presentation. So the way we've structured it was to focus around our recommendations. So our report makes some recommendations which fall into these 4 broad categories. So I'm going to sort of talk about the evidence that we presented, or present some evidence, sorry, that's kind of back up where these recommendations have come from. So hopefully you'll have some useful take-home messages at the end of this. So the first one related to the time. So overall, duration of health checks was perhaps shorter than expected and was very variable. So the range was from less than 7 minutes, so the shortest health check was less than 7 minutes, and the longest was nearly 40. And 60% of those that we recorded were less than 20 minutes. And when we think about how much a practitioner has to achieve within that time, that starts to look a little bit worrying. So we know that they've got to measure CVD risk, and that could include point of care testing. So they might have to do that within the consultation itself. They've then got to have, hopefully, a two-way dialogue about the CVD risk and make sure the patient understands, and then go through the risk management and ideally sort of co-produce a plan with the patients around how to manage their risk, and maybe arrange follow-up appointments or set some things in place for the next stages if required. So arguably 20 minutes would be quite tight for that. 15 minutes certainly tight, and less than 10 minutes I would argue impossible. So that was some of the first findings we had were like this, and it was a bit of a red flag for us that might suggest that process is coming at the expense of quality. although we couldn't tell that just from the quantitative data alone. Another factor related to time was the time spent discussing CVD risk, which was quite short, as you can see. So less than 2 minutes on average, which accounted for about 9% of overall consultation time. There was an indication that more time and a higher proportion of the overall consultation was spent discussing CVD risk when JBS3 was used rather than QRISK2, which is perhaps not a surprise because there's more metrics, there's more stuff to do with that tool rather than just explain a percentage. And then moving on to the second recommendation, some of the data that sort of backed that up was I suppose our assertion that practitioners probably needed to do more to engage patients in CVD risk discussion. And that, again, it started as we started to get a feeling for this from the quantitative data, because that was telling us that these health checks in general were quite practitioner dominated. So overall, practitioners spoke for about 50% of the total consultation time, patients for 20 to 25%. We can look at this thing called a verbal dominance ratio, where anything over 1 is implying that it's somewhat practitioner dominated, and as you can see, there is approaching a significant difference between the QRISK2 and the JBS3, an indication of higher verbal dominance in consultations with QRISK2 versus JBS3. And that was confirmed to some degree as well by when we looked at which patients asked questions about CVD risk. So with the idea that if a patient asks the questions, it shows that they're engaged and they're actually contributing to this discussion. And we saw that about 1 in 3 patients asked a question if they were being told CVD risk using JBS3 versus about 1 in 8 in the QRISK2 group. And this idea that practitioners were dominating the discussion and perhaps just giving information rather than having that conversation was backed up when we looked at the transcripts of the health checks. So here, this is a very typical sort of look when we look at the transcripts in some information from the practitioner. In this case, they're telling them their QRISK2 score. The patient responds, there's an acknowledgement, but there's no sort of interaction, and there's no more interaction invited from the practitioner. And that was really common, sort of single word or just single noise responses from the patient, and the conversation moves on. So that example was QRISK2, but we saw a similar thing with JBS3 as well. So in this example, the practitioner gives the patient their 10-year risk score. They tell them their event-free survival age. They refer to heart age, and they in each step they're trying to show the impact of their smoking status. So this patient's clearly a smoker, and at each stage they're saying it'd be better if you didn't smoke. Essentially, that's the take home. This would be lower if you didn't smoke. You can see the patient isn't silent, but they're not exactly engaging. There's a there's a sigh, there's a cough, and at the end they basically said, "I knew that." So for this example, JBS3 is being used, but it's not really being used particularly well because the patient's not particularly interested and there's no actual engagement. This is a slightly better example in that the practitioner is, I suppose, doing more to explain what the risk means, what the scores mean, try and put it into context. And yet still for this patient, it's not really getting them engaged. There's acknowledgement, but there's no dialogue. There's no, and the practitioner is not really inviting them to get involved in the discussion either. It's, although there's acknowledgement, it's still one-way information provision. So this is our kind of one shining light example, and it's very simple, but it was surprisingly absent from nearly every other health check that we looked at. So here the practitioner relays the patient's event-free survival age, and then just 7 simple words as how do you feel about that, and that invites the patient to actually offer something rather than just it be left up to the patient. In this case, the patient expresses an intention to lose weight, but it's presenting that opportunity for the patient to say, I don't understand, what do you mean, I'm worried, can you say that again? It could be anything, but it was just a surprisingly absent bit of practice from the health checks, and clearly something that is warranted. And that was kind of confirmed again through this assumption in many cases from practitioners that patients understood what they were saying unless they either said that they didn't, or unless there was something obvious from, I suppose, their body language or visual cues within the consultation. So the quote in purple, that practitioner saying, nodding their head, so I think they understood what I was trying to say. And then in the other two quotes, there's a similar sort of assumption, but then it's the practitioner starts to question it. So they're saying it was essentially their perception that the patients understood. It was based on their reactions, but sometimes you wonder actually if they fully understood. And then at the bottom, they seem to be understanding. That's the impression I got. They didn't say otherwise, but perhaps maybe they wouldn't. So again, there's a recognition there that maybe they do need to ask because the patients might not volunteer the fact that they don't get it. And one reason why practitioners might not want to offer that invitation to get involved and kind of invite that discussion about CVD risk is because they don't understand it well enough themselves to be confident to have that conversation. And that is certainly what came through some of our data. These two quotes relate to QRISK 2, so practitioners struggling with trying to communicate the 10-year risk score. So at the top, we've got them, it's described as being the hardest one to put into sentences, or it's hardest to put into sentences. The patients might just say, well, it doesn't make sense. And then the practitioner says, I babble sometimes, even I think I didn't understand that. So they're saying, sometimes I don't understand my own explanation of CVD risk, which is a little bit worrying. And then at the bottom, that quote is an illustration of something we saw which quite commonly, which was an apparent confidence among practitioners in relaying a percentage and perhaps even saying whether that was high, medium or low, and being able to say whether it's essentially good or bad, but actually not knowing what the percentage was. And so why would they invite further explanation or discussion around that if they don't feel sufficiently confident to have that conversation? And perhaps not surprisingly then, there was apparent misunderstanding among the patients as well. So at the top, there's a patient talking about their 10-year risk, their QRISK 2 score, which was 6%, and they think they get it, I think, but they don't seem to. So they describe it as a risk of getting heart disease in life, which it's not, it's about the next 10 years, and they describe it as 1 in 6, which is obviously not the same as 6%. There's some confusion there. In the middle, it's slightly more concerning because this patient has a high risk, so 25 puts them in the high risk category, and therefore there should be some discussion around that and perhaps intervention, but they don't understand whether it's good or bad. So something's been missing from the conversation around that risk score. And then that quote at the bottom, that kind of again highlights the need for practitioners to invite patients to ask questions and question what they're saying. Because this patient's saying, on reflection, as I walked away, I didn't really ask what that meant. So they're kind of wishing that they'd asked what that meant because they didn't understand it, and they obviously weren't given that opportunity to ask. And I've already alluded to this, the practitioner training, when we asked about it, where training had been provided, it was generally on things like using the machine, completing the templates, and just completing the process rather than on communication of risk or how to speak to patients about risk. So we've talked about some fairly fundamental training needs, I think, regardless of what risk calculator is used, but there do there did appear to be some benefits of using JBS3 as a risk communication tool. It's not a clinical decision-making tool. It wasn't designed for that. QRISK2 still serves that purpose, or QRISK3 now as it's being superseded. But there did appear to be some value in some of the features of JBS3, particularly the visual presentation of risk and heart age. So there's probably a bit too much to read here, but this excerpt from a JBS3 conducted health check shows that they used the practitioner used a heart age, and they used the risk modification tool, and obviously the visual displays alongside those. And you can see I've tried to highlight in red that for this patient it works. They're engaged, they're asking, so what impact does exercise have? What's the normal range for HDL cholesterol? And in this case, it's working. But again, it wasn't always the case. Each pair of patients is different, and this is, again, it's a JBS3 consultation. The practitioners imparting similar sorts of information, although perhaps in a bit more of a chunk of information at the top there. But it's not necessarily being done quite so well. So in this example, the heart age is discussed, and the fact that it could be lower if the patient wasn't an ex-smoker. The patient's clearly interested in their cholesterol and what would happen if they lowered their cholesterol, which is the question highlighted in red there, but the practitioner sort of doesn't really engage with that and then goes back to the fact that they're an ex-smoker, and that's bumped it up. So they're focusing on essentially a non-modifiable risk factor. You can't do anything about their ex-smoking status. You can do something about cholesterol. They may appear to want to, and yet it wasn't really picked up, and there's a bit of a missed opportunity. So again, there's the potential for JBS3 to have created an opportunity there, but it wasn't quite picked up on. So it comes back to a training need around the use of that tool as well. Overall perceptions of JBS3 were pretty positive amongst patients and practitioners. The practitioners here, a couple of quotes from two practitioners. They liked it because it's visualized. They think the patients are more engaged with it. Body language is better. They come in closer. They want to ask questions, and also they feel more confidence giving out that way, and it's better than reading it off a piece of paper. And then again at the bottom you can see that practitioner is expressing a preference of delivering heart age over the percentage risk score. Similarly, for patients, they like using the graph. They like seeing the graphics on the screen. And one thing that was mentioned quite a few times was the image of the heart and heart age, and seeing the heart there with a number next to it really did land with some people. It's something they actually remembered. And given that they're being hit with quite a lot of information in the health check, the fact that that landed and they took that message home with them, there's some value in that, certainly. The big health warning with the JBS3 outputs from our perspective is around event-free survival age. Practitioners described it as the hardest one to try to communicate. One of the problems with it appeared to be the lack of a benchmark. So for QRISK2, we've got the percentages, and then they fall into low, medium or high risk categories. For heart age, you've got the inherent comparison with your own age to say, oh, is it up? That's bad. That's quite intuitive. With event-free survival age, there isn't that sort of benchmarking or threshold to apply, so they weren't really sure what to do with it. And perhaps definitely more worrying is the confusion around what it actually was. So it's event-free survival age is the estimated age at which somebody could be expected to survive free from heart attack or stroke. Some people, practitioners and patients, interpret it as the expected age at which you could be expected to survive, so the expected age of death. So for somebody in their 70s who's given an event-free survival age in the sort of the next 5 or 10 years, that's a really worrying thing to be told, and it's not correct. And therefore we would not recommend this being used unless it's supported with a lot more training to make sure it's being delivered accurately and appropriately. So that's it from the findings. So just to summarise those main recommendations again. So overall time, there is a need to do something about this. So it's either making the health check appointments longer or taking some of the admin and process out of the face-to-face bit and making the most of that time where the practitioner is speaking to the patient and improving the quality of that interaction. Which links to this bit around asking the patients and tailoring. What we observed was not really the patient-centered discussion of CVD risk that we know we're kind of aiming for. So that's certainly an area for attention, and that requires training. Training in what the CVD risk scores mean, how to describe them, and also some communication skills to bring the patient in to be more active participants of that discussion. And there is a potential role there for JBS3. It was clearly liked, certain aspects of it, particularly the heart age and the visual displays, were liked and welcomed by patients and practitioners. So there is a potential role for JBS3 outputs or some similar version of that in health checks. Okay, so that's it. That's all I'll say for now. There's a few references there from outputs we've had so far. As I've said, there is the report due soon, and if there's interest, then we can keep this list of all your email addresses and send it out to you when it is publicly available. But I'll stop there and take any questions. I don't know how long we've got left, but we should have a decent amount of time for some questions.
Okay, so thanks. I will just stop the recording.